12 scalpel. Obviously, for surgery, I often use the double-sided 12. That's obviously a bad idea for restorative dentistry because you'll cut the patient's lip or something with the other side while you're not watching. Obviously, whenever you're using scalpels, be super careful because, like any instrument, you can slip, and you don't want to slip and obviously do a massive slice on their lip. Now, with cups, this is a one gloss polishing cup. With cups, I use a diamond burr and I thin the edge, so I run the cup full speed and I put the burr on the inside of the cup while it's running, and I use it to thin the walls of the cup down, because the polishing cups, usually the walls are too thick and they're not flexible enough, so you need to get a coarse diamond burr on the inside of the cup while it's spinning, thin the wall of the cup down so that it's very fine, and then it will kind of flex in between the teeth. That's a tip I got from Craig Erskine-Smith years ago, course in Brisbane, very practical course. Going flat out, obviously be careful when you're polishing teeth like this with the water off, because you can heat the teeth up quite a bit. It's not such an issue, you're very unlikely to kill the tooth, but you certainly want to make sure the patient's numb or they might jump. Now, I can't remember the name of this particular polishing cup. If you're interested, you can send us a message on our Facebook page and we'll look it up for you. Okay, I have a purple one and then an orange one that I use for just about everything from composite to ceramic to gold. And they will, between the two of them, get very high gloss on restorations. Like any sort of composite, the time you spend finishing is often exceedingly important. Now, whenever you have a rubber dam on, you end up with little bits of excess bonding agent at the rubber dam tooth margin, and you can't see it, but the patient will feel it with their tongue. It'll fall off after a few days, but it'll just feel rough to their tongue. So either before I take the rubber dam off or after, I'm going to get a sickle scaler and go around and scratch all that bonding agent off at the gingival margin. I forget the name of that polishing brush. I think it's from 3M. It's one of their brittle diamond coated polishing brushes. There you go, all polished up, nice and smooth, beautiful at the edges. Okay, final cure. Now we're going to move on to the actual frenectomy. Now with frenectomy like this, I want to reposition rather than actually remove it. So I also want to keep it all as minimal as possible. Now in this case you can see that as we put tension on the frenum, the tissue is blanching, so we've definitely got an issue with the frenum here. And it actually displaces the patient's papilla, so it encourages a black triangle. So in this particular case, I'm not taking the incision all the way to the palatal side, I don't need to. I'm just doing the buccal repositioning. So we take the, we've got to have tension on the frenum, and then we do a small incision either side, right down to bone. And you'll notice the moment I release it, all the tension goes out of the whole system. Okay, now I need to kind of undermine slightly. And in this case, I'm going to do a slight Z-plasty. So I'm going to reposition the edges of the wound so that we kind of completely remove all that tension. Okay. So now relieving the other side, and I'm cutting the underlying tissue so that we remove all those fibres underneath that were putting tension on. So you can see that there's still tension there as I'm trying to cut that, the lip's moving down. So we want to remove all of that tension and get that all freed up there. Now I'm also tunnelling in slightly underneath the adjacent areas, changing the scalpel blade frequently, so this is probably the third scalpel blade I've been through. Mostly I use a 15C. Right now I'm using a 15, probably because the staff forgot to give me a 15C. So I'm really trying to get rid of that tissue in underneath the sides of the area. So it's quite a thick frenum, so we want to cut those areas so we don't get any tension between the lip and the papilla. Okay. Now we're going to do sort of an offset closure, and we're going to leave the frenum. So you can see how high that little dangly bit there, that used to be all the way down at the papilla area. Okay, and now you can see it's way up in the lip. So that's how much tension we've relieved, and that section of the frenum will actually stay up there. Okay, I'm just doing a little bit more tissue removal, and just cutting some little side flaps that will help overlap. Now, there's many ways that you can do a frenectomy. I do it multiple different ways. This is just one particular way that I do it. Okay, so if you've seen it done other ways, or if you do it another way yourself, don't sort of get the idea that there's only one way to do a frenal repositioning. Now, that little bit there always leaves a bump on the tissue, so I'm actually going to cut it off. It's actually the bit close to where the papilla was. So we will remove that, like so. And that gives us a much cleaner healing. So now, because this tissue here is really quite delicate, I'm going to use a resorbable suture, just so that I don't have to go back and remove the sutures. When you use a non-resorbable suture in this area, you often have to anaesthetise the patient to get the sutures out, because the sutures can sink in quite deeply unless you're not minding hurting the patient quite a bit. So I'm now suturing that little mini flap to the V shape on the other side. Okay, so that bit of tissue that used to be going down near the gingiva is now going to go horizontal, or from side to side. Okay, and it will completely reposition all that tissue in a different place to where it was, and move all the tissue more apical rather than having any sort of vertical tension. We've now got horizontal tension. Okay, like usual, we'll do several knots, 3 knots. I think I do a double knot the first time one way, and then reverse throw, and then reverse throw for gut suture. This is 5/0 gut, I think. I don't use gut very much because it irritates the tissue as it. So the process whereby resorbable sutures dissolve is an inflammatory process. So obviously you always get more inflammation with resorbable sutures than with monofilaments. And particularly up in this tissue, it's often a good idea to get the sutures out as soon as possible, because firstly, it scars, and secondly, it hurts. So the patients often get pain until you remove the sutures in this area, because the tissue is so delicate, it's always irritable. Now, we're using BioClear matrices here. This is actually my first time using them, so you're not going to see very proficient use in this video. You're going to see quite amateur use. So it took me quite a long time to work out which way they actually go. So just heads up, the little skinny end is the bit that pokes at the incisal edge. That's the bit I'm just cutting off. And the kind of fat end that you wouldn't expect is the bit that goes up into the gingival margin. Now, I didn't want to do both sides at once, so what I've done here is I've positioned them carefully, put a bit of flowable inside one, and then I'm going to go back and do one at a time. That's just acting as a spacer, okay? Now, I probably should have polished that flowable, because you can see there, it's got a slight lip on it that's pushing things slightly one way. And there we go with the light. Now, if we've got any problems, it's too late. And we'll pull that one off. Right, now this is where I realised that you shouldn't aerobrade before you use flowable, because it actually sticks ever so slightly. So I had to scratch all that off, and looks like I didn't. Can't remember if I had to aerobrade. Maybe I did. So this little ledge was getting in the way, so I just gave it a bit of a polish to get it out of the way and sort of allow my matrix to seat better. Okay, there's the matrix going in. Once again, excessive etch. So you can see I'm not just etching a little bit, I'm etching miles away from the tooth. So lots of etch. 15, 20 seconds. Remember, this tooth has already been cleaned of all plaque and pellicle and other things, so it doesn't necessarily. A lot of times when we used to have a minute etch in the old days, that was because we had no way of getting bits and pieces off, and so we had to etch long enough to actually remove the pellicle and plaque and so on. Okay. Now there was obviously some flowable left, so I've had to clean that off with the disc and with the scaler and re-etch again. Obviously I don't mind getting etched on the adjacent tooth because it's all composite resin now. So once again, etching a second time until I get a good etch pattern. Okay, if I don't get a good etch pattern, then I will obviously keep cleaning and etching until I have the tooth perfectly clean and etched. So now we're doing the same thing, opposite side. So getting all that OptiBond in there, we want to get it everywhere. Now, with OptiBond, I do quite different bonding on denting to what I do on enamel. On enamel, I really only want one layer, and then I evaporate all the solvent. Okay. If I'm on denting, obviously I want the denting wet, then I put 2 layers to make absolutely sure I've flooded the moist denting, and then I slowly dry, and then I put another 2 layers. That is a contravention of the manufacturer's instructions, who only says you really need to put 1 lot, but I feel it's much better to put a lot more. I'm not sponsored by Kerr, so I'm not making you use more of their product because of some backroom deal. I'm not sponsored by BioClear either, for that matter, although BioClear did give me free samples of their stuff for a course I ran. So there is the paste composite going in on top of the flowable. So this technique was developed years ago. It was really, I guess, popularised by Paul Belvedere with his injection moulding technique, or his snowplow, or whatever it was called, and then various other people have picked it up, including David Clark, who is the inventor of BioClears. I've been using injection moulding of one sort or another since I went to Paul Belvedere's lecture. In most cases I cure the bonding agent first, and then I use the uncured flowable when I'm putting the paste composite in. Okay, now just spending a bit of time making sure I've got sufficient. So in this particular type of restoration, it's better to have too much. It's very easy to polish buccal and lingual excess off, but very hard to fix a porosity or a hole. So I'm just making sure everything's nice and smooth in there, that I've got no ledges. It's all looking good. So now I've got simple buccal and lingual finishing to do. There's the excess. Now I've obviously got a tiny defect on the lingual of that one tooth, so I've just etched it to clean any oils and contaminants off, and then I'll rebond it and apply a little bit more flowable and possibly composite just to fill in that porosity.